Hello, my name is Natalie Chaser, and I will be speaking to you about osteoporosis. The osteoporosis case study states, a 75-year-old woman from a small rural town was brought to the regional hospital by her son. He reported that she had fallen 6 weeks previously and had been lame ever since, but had resisted seeking medical attention. The patient was lucid and said that she had had no physical complaints before her fall, except periodic back pain that waxed and waned. On physical examination, the physician noted prominent kyphosis of her thoracic spine and exaggerated cervical lordosis. She was unable to bear weight on her right leg and had marked pain on palpation of her upper right thigh. Radiographs revealed a non-aligned fracture of the neck of the right femur, which was surrounded by a large exaggerated callus. There was generalized cortical thinning and radiographic lucidity of her skeleton, as well as compression fractures of several vertebrae. The patient was sent to surgery where the right femoral head was replaced with a prosthesis. A DXA, or a dual energy X-ray absorptiometry scans subsequently showed a marked reduction in bone mineral density involving the opposite femur and spine. Osteoporosis is an acquired condition caused by the thinning of the bones or decreased bone mass, which causes bone fragility or a weakening of the bones, and which causes the bones to break more easily and to fracture. You have an increased opportunity for fractures. Osteoporosis can be confined to certain bones in the body, or it can be generalized to bones. It can be caused by a primary or secondary cause. Primary is most common in people and is caused by postmenopausal or aging. Secondary can be due to a variety of issues like metabolic disorders or diseases, vitamin deficiencies, drug uses, endocrine disorders, GI disorders, osteogenesis imperfecta, immobilization, pulmonary diseases, homocystinuria, anemia, cigarette smoking, and the use of alcohol. Osteoporosis is an inevitable consequence of aging. It is caused when the bone resorption outpaces bone formation of the osteoblast versus the osteoclast. When osteoporosis is caused by postmenopausal, it is usually due to a decrease in estrogen, which causes an increase in bone mass that already occurs with aging, and it speeds up the process. That's why women have an increased risk over men to have osteoporosis. The peak time of bone mass is earlier in life, young adulthood, between the age late 20s, early 30s. After that, you start to lose more bone mass, and this could be influenced by genetic, nutrition, and environmental reasons. The higher the peak bone mass you have at a younger age, it also helps increase the delay of the onset of osteoporosis. Some risk factors for osteoporosis can be having a small, slender body, fair skin, race like whites and Asians are more likely, having a family member that has a history of osteoporosis, having menopause early on in life, smoking, drinking, not getting enough exercise, not eating enough calcium and vitamin D, taking certain medications such as steroids, certain diseases like hyperthyroidism, breaking bones as an adult, and having abnormal menstrual periods or having skipped periods. Other risk factors could be hormonal changes like estrogen, aging, genetics, and other secondary causes. The condition is most prominent in areas with abundant trabecular bone, like the spine and the femoral neck. It says that about 1.5 million Americans each year experience osteoporosis-related fractures, mostly in the vertebrae and in the hips. Like as the case study states, the 75-year-old woman had a fracture to the neck of her right femur, as well as compression fractures to several vertebrae. Like stated, the most often cause of osteoporosis occurs when the balance between bone formation by the osteoblast and the bone resorption by osteoclast tilts. So there's more osteoclast than osteoblast. Thoracic and lumbar vertebral fractures are common. You also could have a loss of height and various deformities like kyphosis. It can also cause severe back pain, and most often the time it is asymptomatic and is very difficult to diagnose until you have it's like fragility, bone fragility, and most often is when you have a fracture of one of the bones. It could come, and it could also come from a strain, a bump, or a fall, and that's when they start to notice that something is wrong. It's stated the best way to diagnose this is through a density test, a bone density test, which is a skilled X-ray called DXA. DXA is dual energy X-ray absorptiometry, or there's also a QCT, which is quantitative computed tomograph. Other ways of testing is through blood tests or other X-rays to help make the definitive diagnosis. Some complications from fractures, especially femoral neck, pelvis, or spine, which causes about 50,000 deaths annually, is pulmonary embolisms and pneumonia. A way to prevent and treat this disease or disorder or condition is adequate dietary calcium intake, vitamin D supplements, regular exercise, anti-resorptive and osteoanabolic agents like bisphosphonates, calcitonin, estrogen are some of the medications. Other ways to prevent and treat is to stop smoking, don't drink too much alcohol, avoid carbonated beverages, excess salt, red meats, excessive caffeine, to have a diet rich with calcium and vitamin D, low in fat, fat-free dairy products, dried figs, dark green leafy vegetables, fish, almonds and juices, breads and cereals with added calcium, and some calcium supplements that could be used beside with also vitamin D supplements could be calcium carbonate and calcium citrate. To exercise regularly with muscle strengthening exercise or weight bearing exercise like walking, and if you need prescribed medications as well. My first research article, titled Genome-Wide Association Study Using Extreme Tourniquet Selection Identifies Novel Genes Affecting Bone Mineral Density and Fracture Risk, spoke about how osteoporotic fractures are a major cause of mortality and morbidity in the population. Decreased bone mineral density is a major predisposing factor to fractures and is highly heritable. Bone mineral density is strongly correlated with bone strength and fracture risk and is a widely used diagnostic tool. The article stated that in 2004, 10 million Americans were diagnosed with osteoporosis, and about 1.3 million suffered with fractures. Hip fractures had a tendency to have a 1-year mortality rate with 36% in men and 21% in women. There are site, gender, and age-specific genes that affect the bone mineral density. In the study, they found that there are 26 known bone mineral density associated genes. The study confirmed and replicated 21 of the 26 known osteoporosis genes. Plus, the research article suggested about 6 new genetic associations in the genes CLCN7, GALNT3, IBSP, LTBP3, RSPO3, and SOX4. The research article also states that a mutation in the GALNT3 causes an increase in bone mass and is associated with risk for fractures. These new findings show how about new mechanisms and how the osteoporosis is acquired and can arise. It also increases knowledge of the etiology of the disease. It highlights genes associated and pathways involved in bone mineral density variations and increased risk for fractures in people to help diagnose, prevent, and treat osteoporosis better in the future. The second article is titled The Pathophysiology and Treatment of Osteoporosis. The article speaks about how the dominant factor leading to bone loss in older adults is the gonadal sex steroid deficiency with genetic and biochemical factors like vitamin D deficiency or hyperparathyroidism. All these factors could lead to accelerated bone loss that is associated with osteoporosis. Conditions that affect growth and development may also lead to bone loss. Osteoporosis is a skeletal disorder characterized by diminished bone strength that results in increased fracture risk. And bone strength is one of the functions of bone mineral density. It occurs in both men and women as part of the natural aging process. The article stated that about 40% of white women aged over 50 years will experience an osteoporosis-related fracture, and 13% of men will experience an osteoporosis-related fracture. Ways of diagnosing the loss of bone loss is by the DXA, or the QCT test, which is quantitative computed tomograph. The article also stated that large decreases in the bone mineral density begins as early as the third decade in both sexes, ultimately leading into a lifetime loss in like the spine and the hip areas. With hormonal changes that help decrease bone loss in women with menopausal onset of ovarian failure, estrogen concentrations decline rapidly, and this decline is closely paralleled by a period of accelerated and progressive bone loss in women. The article stated, although measured rates of bone resorption and formation are approximately matched before the menopausal onset due to the coupled relationship between bone-absorbing osteoclasts and bone-forming osteoblasts, the decreased estrogen concentrations associated with menopause result in increase in bone reabsorption and formation, with reabsorption outstripping formation, which helps increase bone loss in women. Biochemical markers can also be tested and measured in blood or urine. With the diminished estrogen concentrations, the RNKI concentrations increase and the OPG concentrations decrease. Together, this increase in the ratios results in increased osteoclastogenesis, and increased osteoclast activity. Also, the article stated that estrogen also suppresses expression of a variety of other cytokines produced by cells of the bone marrow, which were shown to play roles in bone resorption, and some of these cytokines are the macrophage colony stimulating factor, interleukin-1 and interleukin-6, tumor necrosis factor, and progesterone. With the estrogen decline, there is a rise in circulating concentration of follicle-stimulating hormone (FSH) due to the loss of the feedback inhibition. This is shown to correlate more closely in premenopausal women with decrease in bone mineral density at the hip and spine. On the other hand, men undergo an increase in sex hormone binding globulin concentrations over the lifespan. This increase concentration and with the testosterone decline testosterone can undergo turning into estrogen, which can increase the estrogen concentration. And research shown that men that have less bone mineral density is more closely related with circulating bioavailable estradiol concentrations than with testosterone concentrations. Other factors associated with bone loss that are outside the non-sex steroid hormonal changes are growth hormone secretion by the pituitary glands, or a diminished hepatic production of IGF-1 and IGF-2 hormones. Other factors are like medication like corticosteroids, antiestrogens, and antiepileptics, endocrine disorders such as hyperthyroidism, hypogonadism, diabetes mellitus, and vitamin D deficiencies, rheumatologic conditions including lupus and rheumatoid arthritis, and also neurological conditions such as spinal cord injury or Parkinson's disease. Hematological diseases include monoclonal gammopathy, multiple myeloma, malabsorptive conditions such as celiac and inflammatory bowel disease, and bariatric surgeries, transplantations, and other various conditions could also induce increased skeletal fragility. Treatments for osteoporosis that are non-pharmacological could be limiting the risk of falls, using proper techniques when lifting, maintaining adequate intake of calcium, vitamin D, and protein, performing adequate weight-bearing physical activity and exercise to maintain or improve balance and posture, making appropriate lifestyle changes such as smoking, decrease or eliminate smoking, and moderate alcohol intake. The pharmacological interventions to treat osteoporosis are anti-reabsorptive agents for the treatment of osteoporosis by eliminating the osteoclast activity, and there's also osteoanabolic agents that act primarily by stimulating the osteoblastic bone formation. They also use estrogen or selected estrogen receptor modulators, bisophosphonates, and current research is finding that greatest potential for a new agent for treatment is by changing and inhibiting of the cathepsin K and sclerosis, or the sclerostin. The researchers are hoping that with more understanding of osteoporosis and deeper understanding of the pathophysiology, they can find better treatments to help prevent and decrease risk for people with osteoporosis. The third article is titled "The Molecular Mechanisms Underlying the Pharmacological Action of Estrogen, SERMs, and Oxysterols, Implications for the Treatment and Prevention of Osteoporosis." The research states that estrogen therapy and hormone therapy are effective for the prevention and treatment of osteoporosis. However, it's recommended that they're not used long term due to the significant side effects. And due to this, advances have been made in therapies and treatments into SERMs, and also development of TSEX, which is tissue-selective estrogen complexes, a new class of conjugate. The research states that there is an increased risk of osteoporosis in women subsequent around the same time as the cessation of ovarian estrogen production that occurs during the time of menopause. The most notable information from the research article was that the development in the field of biology with the new class of medicine, the TSEX, which is tissue-selective estrogen receptor complexes. They combine an SERM and an estrogen, and the blended activities of the constituents result in a clinically useful profile for osteoporosis. Research has found that this treatment effectively reduces and treats the symptoms of osteoporosis associated with menopause and prevents bone loss without any negative impact on breast or in the uterus, like previous medications that were being used by osteoporosis patients. Also mentioned was that hypercholesterolemia is a risk factor for osteoporosis. It's shown that estrogens can have an impact on cholesterol and on bone, cholesterol on bone. And postmenopausal women have a resulting increase in the TLHC, which will exhibit a negative impact on the bone with the cholesterol. Cholesterol is a modifiable risk factor that can be controlled by statins and by dietary changes in the postmenopausal women. And the next generation of SERMs, which was mentioned as a new treatment, can also have beneficial factors of like classic estrogens, and will not increase the risk of breast or uterine cancer like estrogen does, and also do you have a decreased risk for DVTs and strokes. These new classes of SERMs are optimized by a particular biological response like anti-resorptive activity and are screened against negative sequences to manifest in other target tissues that are not needed. They're being made to identify process selective. And these are just some of the types of new treatments that are coming out with advanced technology and advanced research in osteoporosis and the hope for the future for patients. Overall, all three articles correlate with the case study of the 75-year-old woman that was brought into the hospital by her son because she fell 6 weeks previously and became lame and weak. The articles mention that a fall is a big risk factor for complications of osteoporosis. Another factor that they, like a sign or symptom they noted in the case study, was back pain, which is also noted in the articles. Also is noted in the article is the various deformities in like the spine and such in patients, like in the case study with her kyphosis of the thoracic spine and exaggerated cervical lorotus. Another thing in the case study that correlated with the osteoporosis research articles mentioned, was that she was at a high increased risk for fractures, especially like the femur, which she had a non-aligned fracture of the neck of the right femur, and also that she had cortical thinning, and she had a compression fracture of several vertebrae, which is also noted that the vertebrae and the femur are very high risk with patients with osteoporosis. The woman is also a 75-year-old woman, which is she's older, but also she having the age issues with osteoporosis, as mentioned in the articles. But also she's postmenopausal, which is also associated with an onset of osteoporosis. Ways of diagnosing or looking at bone mineral density in patients is by using the DXA, which was used in the case study, which is dual energy X-ray absorptiometry, that showed in the case study that she had a marked reduction in bone mineral density in the femur and spine. And also another mentioned research articles that could also be used is the QCT. I found the 3 research articles to be helpful in understanding the pathophysiology and treatments and advancements in treatments, and ways of diagnosing and preventing osteoporosis in males, and not just males but also women, understanding both factors with patients. Overall, all 3 articles were helpful in having an overview and a greater understanding and growing of knowledge in osteoporosis.